And welcome to Lesson 5, where we will review another pediatric mental health problem, selective mutism. And the verse guiding this lesson is from Proverbs 31, verse 8. Speak up for those who cannot speak for themselves, for the rights of all who are destitute. Selective mutism is a rare but disabling disorder, and it is characterized by a consistent failure to speak in specific settings. So, not all settings. So, they may speak normally in some settings and then inconsistently or not at all in others. And it can cause significant social and academic impairment if it is untreated. Selective mutism was identified early on by a neurologist in 1877 under the term aphasia voluntaria, and then in 1934 further clarified by a child psychiatrist as elective mutism. 1994 became the classification of selective mutism in the category of disorders first diagnosed in infancy, childhood, or adolescence. And in 2013, selective mutism was classified as an anxiety disorder. The clinical presentation of this disorder is that it is, again, specific only in certain contexts or certain situations. And it may also only be with certain people. The individual typically will do better with a friendly, funny, outgoing, talkative person. And typically, the selective mutism is with an adult, that they are often easier to talk to other children and can whisper to a friend. And they do differ widely in their use of nonverbal communication. Some may and some may not. School refusal is rare, but can be comorbid along with other anxiety or specific learning disorders. It is more common with immigrant or bilingual children as well. And the onset typically is between 2 and 5 years. And typically, this is a very anxious child who is perhaps overly shy and fears mistakes and does not like to be the center of attention. And the vicious cycle that can occur with selective mutism is that when the child eventually does talk or talks in a different setting or context, they can have such a reaction from the individuals or the adults around them, well intentioned, very positive and happy that the child is talking finally, but the reaction is often very anxiety provoking for the child, which then reinforces future mutism. So it can become a vicious cycle. So, really, helping the adults and caregivers working with the child to understand the need to have that neutral kind of effective response to the child's changing behavior when it occurs. So let's look at our case study. Anne, who is a 5-year-old girl, and she has had mutism since pre-kindergarten at the age of 3. Otherwise, she had a very normal development. Her temperament was noted to be very shy and introverted, like her parents. She was lively, happy, and talkative at home. However, She felt very uncomfortable and shy around her paternal grandparents and would never speak in front of them. The parents often speak for her outside of the home because her anxiety is so severe. She only communicates nonverbally at school, even after attending for a few months. The other children often will speak for her and include her in their activities. There's no one specific cause for the development of selective mutism. It has been identified to be more of an act of willfulness rather than a lack of ability to speak. And again, may occur only in select settings or select individuals. But there are many contributing factors, and these include genetic factors, temperament, neurodevelopmental development, and the environment, um, personalities, and relationships in the environment as well. Diagnostic criteria include consistent failure to speak in specific settings despite talking normally in others, and it must occur for at least 1 month. It is not due to a lack of knowledge or comfort with the required language. It is not better explained by another communication disorder, and it does not occur with a child with autism, schizophrenia, or any other psychotic disorder. And it should interfere with their daily functioning at school and in social situations. And the key diagnostic question is, does the child speak normally in at least one setting, such as at home, but show mutism in other settings, at school? If yes, ask the parents to elaborate on the clinical presentation of their child's speaking behavior. How long has the muteness lasted? Remember, needs to last at least a month. And what has been done or tried to help the child? Now, it is crucial to make sure that the child does not have a hearing problem with any type of communication disorder, and then getting information on the child's developmental history, including milestones as well as pregnancy and inter exposure, and try to elicit any experience of psychological trauma or actually a physiological trauma or brain injury. Information on the academic functioning is needed, and the ability to assess their intelligence or nonverbal language skills. And there are some challenges with diagnosing selective mutism. It does often overlap with other disorders, such as social phobia or separation anxiety disorder or other specific phobias. So, eliciting the mutism and the length of time for that symptom is important. And they may speak okay in some settings, but there needs to be some impairment from their mutism in other settings. Bilingual children can be overlooked, but if the symptom lasts longer than 6 months, it's important to identify whether it's occurring because of a lack of understanding of the new language and if there are any other comorbid speech or language disorders. 90% of children with selective mutism also meet criteria for social anxiety disorder. They may have separation anxiety, but not necessarily school refusal. And neurodevelopmental disorders are common as well. Many may also have a speech and language disorder, elimination disorders such as encopresis or enuresis. There may be delays in milestones such as in sitting up and walking. And less than 10% of the cases actually have a comorbid autism. And ADHD is rare with selective mutism. So it is no longer viewed primarily as oppositional, just oppositional when pressured to speak. So again, it is willful in that it is selective, but however, um, it is not defiance per se. It's important to gather data from both parents and teachers, and there are a number of diagnostic interviews, questionnaires, and rating scales that can be used. And oftentimes, a patient presenting with select mutism will be selectively mute for the assessment. So the interviewer needs to ask a lot of yes and no questions and encourage nonverbal communication. And written questionnaires can work quite well as well. So, some self rating scales and the need to use talking maps and feelings thermometers. So, whatever way you can facilitate communication. And careful consideration of the approach to developing a rapport with a child with selective mutism is important. It's helpful to tell the child that they do not have to talk to you before beginning. So, taking some of that pressure off. Also, ask the child if they would like the parents to join in the session. It's important to promote some nonverbal options such as pointing, nodding, or writing. And you want to sit beside rather than opposite. And no time limits. Again, we're trying to decrease the stress and pressure when doing any rating scales. And it's helpful to uh, incorporate some play activities and choose neutral conversation topics. Be sure to allow periods of silence to give the child time to answer and continue the dialogue even if they are not responding. You can speculate what a response that they might make and seek their confirmation. And homework assignments for the parents can include recording speech for the therapist. So perhaps sending home a list of questions for the parent to record when the child is feeling safer. And behavioral rating scales that can be helpful for selective mutism include the Revised Children's Anxiety and Depression Scale, or specifically the Selective Mutism Questionnaire for parents. And there is a school speech questionnaire for teachers, and then the Social Communication Anxiety Inventory as well. And it's important to guide treatment specifically for the individual. And so identifying their vulnerability factors, what kind of things are going on um, underneath the selective mutism? Is there a separation anxiety, a very shy temperament? Is there a genetic factor, neurodevelopmental disorder? And then I look out for any triggering factors. What seemed to happen at the onset of the mutism? Was it starting a new school or a new language, a relocation or moving, some type of transition? So be on the lookout for that because that will guide treatment as well, helping the child with adjustment to the new setting or the triggering factor. And then sustaining factors. So, what may be going on that's reinforcing the behavior, either positively or negatively? So, it could be either too much acceptance of the non speech or too much pressure put on the child to speak. Cognitive behavioral therapy is the therapy of choice with a focus on decreasing speech anxiety, graduating exposure tasks, and rewarding speaking behavior. So, some type of contingency program that is shaping more pro social communication. And pro-social treatments can include also psychoeducational literature for the parents as well as the teachers. Pharmacotherapy is not generally indicated, though may certainly treat any comorbid disorders such as social anxiety disorder or separation anxiety disorder. So, pharmacotherapy may be utilized in addition to the therapy as well. Different protocols are available as well. And one such protocol is the social communication anxiety treatment. It's a type of psychotherapy that involves 9 sessions 3 times a week, and parental participation is used as well with homework assignments, things to do in between sessions, and it does involve increasing the demand for verbalization stages using a social communication comfort scale. And it was seen to have an increase in speech by parental ratings in the pilot of 40 children, and as well decrease symptom severity and have better outcomes overall. And again, so medication management would be off label unless treating a comorbidity. And there is some evidence, though, for the treatment of selective mutism with fluoxetine as well as sertraline. There certainly are the typical GI side effects that can occur, but medication should be used in concert with therapy. They go hand in hand. Usually, the child will need to fail a therapy alone approach when looking at selective mutism. Again, unless there's a comorbid, separation, or social anxiety disorder. And the symptoms would need to be severe and handicapping or impairing in some way. And typically, medication management is used more often in older children. So, in conclusion, selective mutism is relatively rare, although it causes significant social and academic impairment. The cardinal symptom is consistent failure to speak in certain settings despite speaking normal in others. It does tend to run in families, so there is genetic and also environmental factors. And it is associated with behavioral inhibition or very shy temperaments. There are some prevalent comorbidities that include anxiety as well as neurodevelopmental disorders. And it is important to get information from parents and teachers. And so rating scales are available for that. And the first step, psychoeducation and behavioral management. gradual exposure and rewarding increasing speaking behaviors with the incentive of their choice. And so these are going to be your best approaches. Again, medication management, if it's a comorbid disorder going on, or if the disorder does not respond to therapy alone, or is severely disabling.